Cancer of the esophagus. Malignant lesions of the esophagus occur in 4 types: squamous cell, adenocarcinoma, carcinosarcoma, and sarcoma. Pathophysiology and etiology. The incidence of adenocarcinoma of the distal and middle third of esophagus appears to be increasing in the Western world. Squamous cell carcinoma, most often originating in the upper half of the esophagus, appears to have an equal incidence to adenocarcinoma. Male who are older than 60 years, more common in non-white males, there is a highest rate of this carcinoma. Associated factors: cause is unknown but has been associated with Barrett's esophagus, achalasia, chronic use of alcohol and tobacco that cause squamous cell carcinoma, genetic predisposition, non-white male population, ingestion of caustic substances such as lye, which cause esophageal strictures, other head and neck cancers. Clinical manifestations: dysphagia is the usual presenting symptom, although it is a late sign, but with the time there often is a regional or systemic involvement. Mild atypical chest pain associated with eating precedes dysphagia, but rarely significant enough for the patient to seek health care. Pain on swallowing, that is odynophagia, progressive weight loss, hoarseness, laryngeal involvement, if there is laryngeal involvement, lymphadenopathy, supraclavicular or cervical, or hepatomegaly with metastatic involvement. Later symptoms: hiccups, respiratory difficulty, foul breath, regurgitation of food and saliva. Diagnostic evaluations: chest X-ray may show adenopathy, mediastinal widening, metastasis or a tracheoesophageal fistula. Second one, endoscopy with cytology and biopsy. Third, barium esophagogram may show polypoid, infiltrate or ulcerative lesion requiring biopsy. CT may be helpful in delineating the extent of the tumor as well as in identifying presence of adjacent tissue invasion and metastasis. Management: the goal of treatment may be cure or palliation, depending on the staging of the tumor and the patient's overall condition in relation to nutritional, cardiovascular, pulmonary and functional status. The wide variability in treatment reflects the overall poor results from any one approach. First one, surgery. Lesions of the middle and lower esophagus are excised with use of thoracotomy approach with esophagogastrostomy or colon interposition, that is section of colon is used to replace the excised portion of the esophagus. Second, lesions of the cervical esophagus are excised with a bilateral neck dissection and esophagogastrostomy. Laryngectomy and thyroidectomy may be necessary. Third, a two-step approach may be selected when resection with a cervical esophagostomy and feeding gastrostomy are performed initially. Subsequent reconstructive surgery is performed. Fourth one, radiation, chemotherapy or their combination. Combination therapy appears to have better results. Palliative treatment of dysphagia through dilation done by endoscopy or laser therapy. Sixth one, the goal of palliative treatment is to reduce the complications of the tumor to improve quality of life. Any one of or combination of the aforementioned therapies can be used for palliative treatment. Complications: preoperatively, malnutrition, aspiration pneumonia, hemorrhage, sepsis, tracheoesophageal fistula. Postoperatively, dumping syndrome, nutritional deficiencies, reflux esophagitis, anastomosis, leakage. So the management, once again, palliative treatment, surgery, Lesions of the middle and lower esophagus are excised through thoracotomy approach, and a portion of colon is replaced in the where excised portion of esophagus is removed. Second one, lesions of the cervical esophagus are excised with a bilateral neck dissection and esophagogastrectomy. And two-step approach were selected, the cervical esophagostomy and feeding gastrostomy. Radiation, chemotherapy, palliative treatment, and through dilation done and endoscopy, laser therapy. Thank you.